Hello everybody, welcome. We start with our second session of ARDS, that is PEEP strategies and recruitment maneuver. So as I told you, we will be dealing ARDS very slowly because it is the bread and butter for a critical care physician. Now we know what is ARDS, definition of ARDS, the various criteria for defining ARDS, and what are the strategies to manage ARDS, and what are the ventilatory parameters, what lung protective ventilation strategies you are supposed to follow. So once you put the patient on ARDS and initiate him on LPV, that is your lung protective ventilation as per the AMA trial, then you have your next aim should be to see an improvement in the oxygenation and an improvement in the compliance of the lung. So this just doesn't happen by putting a patient on lung protective ventilation or giving a low tidal volume and just waiting. No, you again have to act up to improve the lung, to recruit the alveoli, to open up the alveoli, to simultaneously prevent the villi, that is atelectrauma, barotrauma and biotrauma and volutrauma. So the first step after you put the patient on ventilator and aim for an improvement in oxygenation compliance is your PEEP strategies and your recruitment to open up your lung. So in this class we will see like what are the various strategies wherein you can have a bedside strategies to improve your PEEP and to finally have an improvement in oxygenation. So the indications to apply PEEP, we know as a part of LPV to minimize villi, because repeated opening and closing of the alveoli with the positive pressure ventilation definitely causes some amount of atelectotrauma. Then as you give PEEP, you involve maximal units of lung. So suppose if this is a lung and you have this alveoli, you have the basal alveoli. So if you give PEEP to a lung, you even involve the basal alveoli in an equivalent manner as you involve the upper or the middle lobe alveoli. So you involve the maximal units of lung to participate in ventilation, thus minimizing the stress and strain on the lung. And one more thing is, whenever you give PEEP, you cause some amount of stress raisers. That is, if the basal alveoli are collapsed. So whenever you give PEEP, I mean to say whenever you give some positive pressure ventilation, for the basal alveoli to open up, it causes lot of stress. Then again it closes. Then another bout of positive pressure ventilation comes and again opens up and causes a stress on the walls of the alveoli. So whenever there is some amount of PEEP given and the alveoli are kept open, especially the damaged alveoli or the inhomogeneous alveoli, if they are kept open throughout the ventilation cycle, that is during inspiration and expiration, the amount of stress which is induced on them in this inhomogeneous part of the lung is definitely reduced. So what happens is, whenever you inflate these stress raisers or these damaged alveoli, there is 5 times the stress which is compared, which happens, then you open up a homogeneous collapsed lung. See, whenever there is a good lung and you keep on opening it and closing it, it causes some amount of atelectotrauma due to the positive pressure ventilation. But if the same opening and closing, the atelectotrauma which happens to a non-homogeneous lung or a damaged lung, there is a stress raiser or the stress which happens in a damaged lung, which is 5 times more than in a non-damaged or a homogeneous lungs. So definitely PEEP is not only reducing the atelectotrauma to a baby lung or the normal lung, but also to a stressed lung or a non-homogeneous lung. It is reducing the stresses raisers. So what is the evidence guiding PEEP? Definitely a meta-analysis including 18 randomized trials with 4,646 patients showed that in a moderate to severe ARDS, if you give a good amount of PEEP or a higher PEEP with some amount of recruitment of the lung, it has shown to have a mortality benefit. That is, the higher PEEP with recruitment maneuvers the higher PEEP has shown to have a mortality benefit. Even a post hoc analysis of a lung open ventilation strategy trial showed that ARDS patients who were given a good amount of PEEP showed improved oxygenation and improved compliance of the lung than the patients who were not given great amount of PEEP. So what are the guidelines helping us to guide? So there is an expert opinion which says that PEEP is definitely an essential component in the management of ARDS, and at least a minimal PEEP of 5 centimeters of water is necessary for all patients of ARDS. Beyond that also you can go, that is individualized basis from patient to patient approach. But the expert opinion says that for every patient of ARDS, 5 centimeters of water of PEEP is necessary. Then there is a grade 2 evidence but a strong agreement saying that higher PEEP strategy should be followed in patient with moderate to severe ARDS. So very strong agreement. And again there is an expert opinion which suggests that higher PEEP should be reserved to improve oxygenation, but especially in the situation where in spite of giving higher PEEP, there is no marked deterioration of respiratory system compliance and hemodynamic status. So you have to be very sure whenever you apply higher PEEP, you have to have an eye on two things.